Hello everyone. Today we talk about NSAIDs and whether you should use it in inpatient setting because you might be worried about acute renal failure. A nurse calls you about a patient who is now having back pain of 10 out of 10 severity, and the most common thing that residents would go for is some form of opiates. It would appear that NSAIDs are not adequately used in inpatient settings. When I used to rotate in my outpatient setting with my primary care providers, Tylenol and NSAIDs were the first line of pain management. However, in inpatient settings, you are always told that NSAID can cause renal failure and other side effects like GI bleed or bleeding from other areas, and you develop a bad habit of not using NSAID in inpatient settings. So let's look at why there is so much discrepancy among NSAID use. To this, you have to understand pathophysiology of NSAID and examine the evidence behind the renal failure. In this lecture, we will not discuss the problem of NSAIDs and GI bleed, which can prevent their use in inpatient settings. NSAIDs block the cyclooxygen pathway in biosynthesis of prostaglandins. Prostaglandins and prostacyclins are important molecules that help perform various functions in the body. Since we are talking about blood pressure and hypotension, we'll focus mostly on the vasodilator and vasoconstrictor responses. So PGI2 and PGE2 are vasodilators and thromboxane is a vasoconstrictor. NSAIDs will block their production and will have different effects on different tissues depending on the relative concentration of thromboxanes versus prostaglandin or prostacyclins. There are two types of cyclooxygenase, COX-1 and COX-2. COX-1 is a constitutive enzyme, which means it is always present in those tissues, such as stomach mucosa, platelets, etc. COX-2 is an inducible enzyme induced by inflammation and injury. COX-2 is also present in kidneys, where it plays a physiological role in renal development. Different types of NSAIDs have different COX-1 and COX-2 selectivity. For example, celecoxib is highly COX-2 selective, while ketorolac is mostly COX-1. Rest of the NSAIDs lie somewhat in between. In kidneys, COX-1 causes vasodilation by production of prostaglandin E2 in renal arterioles. It also increases the secretion of renin. COX-2 in kidneys antagonize water excretion by ADH, as you will see in subsequent slides. Action of prostaglandin and prostacyclins are local. So as your COX-2 activity increases, your prostaglandin E2 and I2 increase and result in vasodilation. So let's understand how your body responds to low blood pressure situation. That's where the renal failure comes in. In patients with hypotension, your renin-angiotensin aldosterone system is activated. And if you remember, angiotensin 2 act on your AT1 receptors and causes vasoconstriction to maintain your blood pressure. This is also aided by your sympathetic nervous system, such as norepinephrine and epinephrine, which works on your alpha-1 receptors. In kidneys, angiotensin 2 vasoconstricts both afferent and efferent arteriole. Your norepinephrine also works on the efferent arteriole to cause vasoconstriction. Both these effects result in maintaining of your GFR, however, the real blood flow decreases to the kidneys. Angiotensin 2 and norepinephrine also stimulate your COX pathways to produce prostaglandins, and prostaglandins are important because they are vasodilators. They prevent the excessive vasoconstriction caused by angiotensin 2 and norepinephrine. So if you give NSAID to these patients, you disrupt the production of prostaglandins, and this results in an unopposed excessive vasoconstriction, depending on the severity of sympathetic nervous system and angiotensin 2 levels, which is highest in shock or severe hypotension. So this can result in severe drop in renal blood flow, very decrease in GFR, and sometimes acute renal failure. So NSAIDs can cause renal failure when it's used in patients with decreased renal perfusion, i.e. those patients with increased angiotensin 2 or sympathetic nervous system activity. In persons with normal renal hemodynamic parameters, prostaglandins do not play a dominant physiological role in maintaining the renal blood flow. So effect of NSAID on renal blood flow is very small in a normal person. Let's understand this in a bit more detail to find out who is more susceptible to NSAIDs in inducing acute renal failure. So you need good blood pressure, which perfuses all organs, which includes kidneys, and these are sensed by your carotid, aortic, and receptors in your kidneys present in your macula densa and JG apparatus. So there are three variables that control your blood pressure. First is your cardiac output, which is your contractility and heart rate, blood volume in the arterial compartment, that is your effective circulating volume, and vascular resistance. one of the things that I want to make sure that you understand that effective circulating volume is not same as volume status. ECV is amount of blood in the arterial compartment because this is the blood that generates the blood pressure that perfuses your organs. The blood in the venous side or your body fluid in ECF or ICF do not contribute to generating blood pressure. So you can be hypovolemic or hypervolemic but have low effective circulating volume. So let's look at the reasons behind why you have decreased effective blood pressure. First thing, you can have problem with decreased cardiac output, for example, heart failure, cardiogenic shock, or obstructive shock. You can have decreased effective circulating volume, such as seen in true hypovolemia, or redistribution of blood flow, for example, venodilation or splanchnic vasodilation. Or you can have vasodilation in the peripheral system, decreasing the systemic vascular resistance, for example, sepsis, cirrhosis, AV fistula, etc. And all these conditions will trigger your sympathetic nervous system and angiotensin II activity. So all these will be very prone to NSAID-induced acute renal failure. So the reason you see a discrepancy of NSAID use between your ICU doctors and your primary doctors is mostly because we see patients with decreased ECV more commonly. So we observe that the rate of renal failure is much higher with NSAID than is observed by primary care doctors. So both of them are right in their own perspectives. And this is one of the reasons why understanding pathophysiology helps you understand which group of patients will be at higher risk so that you can personalize the treatment. So avoid NSAID in those with elevated SNS or angiotensin II activity as they are prone to NSAID-induced AKI. This study used indomethacin or ibuprofen in patients with cirrhotics and measured their creatinine clearance, and you can see that the creatinine clearance drops by 50% within 1 day use of NSAIDs. Prostaglandins are also involved in renin production. The baroreceptors and the cells in macula densa use prostaglandins, which stimulate the production of renin. If you give NSAIDs to these patients, you can result in decreased renin production, and this results in hyporeninemic hypoaldosteronism. This can result in reduced potassium excretion, resulting in hyperkalemia. Mean potassium rise from NSAID in normal kidneys is about 0.2 milliequivalent per liter. However, in CKD, the mean rise was observed to be 0.6 milliequivalent per liter. Since this is mean, you can see that certain patients can have significantly higher rise in potassium with use of NSAIDs. ADH also stimulate prostaglandin secretion, and these tend to inhibit the ADH function by reducing the rate of aquaporin channel acquisition. So prostaglandins keep ADH in check and prevent a lot of free water absorption, therefore prevent hyponatremia. If you give NSAIDs to these patients, you can stop this feedback inhibition from the prostaglandin, and in susceptible patients with hyponatremia, for example SIADH, you will have increased free water absorption. Minimum urine osmolality can rise from 50 milliosmol per liter to 200 milliosmol per liter if the patient is on NSAIDs. Prostaglandin E2 also inhibits sodium reabsorption in cortical collecting duct, resulting in natriuresis. However, under normal circumstances, since prostaglandin activity is not stimulated, this result is minimal. However, in hypovolemic state or hypotensive state, you can lose a bit more sodium. And you'd think that this is bad because you're losing some salt. However, this is one of the way your body responds to prevent the cortical collecting duct, which we understood earlier is in a relatively ischemic area, from using too much energy in hypoperfused state. When you give NSAID to these patients, you can abolish the effect of prostaglandins and can result in sodium retention. This is one of the reasons why NSAID use in patients with heart failure can antagonize diuresis, because prostaglandins inhibition results in sodium retention. So in a way, angiotensin II controls most of the renal blood flow activity. However, prostaglandins tries to keep it in a bit of check with its function. If you remove prostaglandin from the picture, angiotensin II can result in more injury. So let's see what is the evidence of NSAIDs and renal failure in inpatient settings. Most of the nephrologists will tell you that NSAID use can result in worsening renal failure and higher rate of patient progressing to chronic dialysis. The adjusted odds ratio in this study was 2.73 for non-selective NSAIDs. However, we are looking at an inpatient settings, but realize that nobody is going to do a randomized controlled trial in this setting because NSAIDs are known to have higher risk of causing AKI and GI bleed in this group. So only data we have is from observational studies. This was a large study which looked at around 96,000 patients with critical illness and looked at their NSAID use. And they found that incidence of AKI with renal replacement therapy was 2.71 in patients exposed to NSAID versus 2.24 with those who are not. So they calculated as risk of developing AKI as 8 patients per 1,000 exposures. But one of the things that I would like you to think critically is think about those patients who will be on NSAIDs. These will be the patient with inflammatory disorders, cardiac disease, etc. So it should not surprise you that they will develop higher rates of AKI. So it's very difficult to differentiate if this AKI was developed from NSAID use or from underlying disease. The PADIS guidelines from critical care medicine also does not suggest routinely using COX-1 selective NSAID for pain management in critically ill patients. So bottom line, avoid use of NSAID in those with elevated sympathetic nervous system or N2 activity, and these are the patients with low cardiac output, increased vascular resistance, or low effective circulating volume. What about baby aspirin? Can this cause similar problem with worsening renal function in an ICU setting? There's hardly any literature on that, but this was a good study which looked at elderly volunteers. They did a good job of giving them diuretics to stimulate your renin-angiotensin system and also gave them ACE inhibitor as well. And you can see that the GFR does not differ between no use and 80 milligrams use, while your GFR progressively drop as you use higher dose of aspirin. According to the study, use of aspirin up to 80 milligrams was safe even in compromised patients. As per National Kidney Foundation, there is no evidence of risk regarding regular use of aspirin in small doses recommended for prevention of heart attacks. Use of baby aspirin is fine even with reduced kidney function. However, this statement is for outpatient patient only. The question we are trying to figure out is, does aspirin 81 milligrams worsens renal failure in ICU patient? So if a patient is going into septic shock, would you still continue aspirin or not? And there's a lot of observational studies and opinion pieces in the literature, and there's no clear answer. One of the interesting study was this anti-sepsis study, which was randomized double-blind placebo-controlled trial, and they did not observe any difference in death contributed by sepsis when aspirin was compared to placebo. One of the things I would like to talk about is when you read the literature, try to avoid extrapolating data from observational studies. It is certainly okay to read them and understand different hypotheses if randomized controlled trials are not available. Think about publication bias. For example, in this case, who do you think will publish a negative observational study of trial of aspirin in ICU? So all you see is the positive studies. So you presume that aspirin improves outcomes in sepsis or hypotension. Again, go for a good peer-reviewed journal. There's a lot of pressure to publish, and open access in many journals is now money-driven. Search for randomized controlled trial and good meta-analysis, and always keep a skeptical view. Understand the underlying pathophysiology and see how it relates to your patient. Real answer is nobody knows if aspirin 81 milligrams does any harm to the kidneys. So bottom line, in inpatient setting, short-term NSAIDs are okay to use in patients with normal renal perfusion and renal function. Avoid NSAID use in those with low cardiac output, increased vascular resistance, and low effective circulating volume. There are other risk factors associated with developing AKI and CKD with NSAID. These are older age, males, higher BMI, African American race, and comorbidities such as heart failure, nephrotic syndrome, cirrhosis, atherosclerosis, etc. Since now you know the underlying pathophysiology, you can understand the common factor among all these risk factors is baseline elevated sympathetic nervous and angiotensin 2 activity. These are the references. The main takeaway point in this lecture was to identify the group of patients in which NSAID can cause more harm and understand the reasoning behind this, and understand the complexities of medical decision making. Once you understand the underlying pathophysiology, you would be able to personalize the management and understand why different group of doctors treat the same condition differently. Thank you.